Good morning, good afternoon, colleagues. Welcome to APMEN TechTalks series. And today we are focusing on exploring safety of higher dose of Primaquine while advancing towards Vivax elimination. I am Neena Valecha, Chair APMEN Vivax Group and former Regional Advisor Malaria from WHO Southeast Asia Regional Office. And as such, I have been a researcher for more than 30 years and contributing to ICMR. So today I'll be moderating this session. And I do have with me the APMEN Vivax Group team, Dr. Caroline Nitsch, co-chair of APMEN Vivax Working Group, and who's also Regional Advisor for Medicines for Malaria Venture. Caroline, would you like to switch on your video for a second? And Dr. Manesh Shrestha, Technical Coordinator, APMEN Vivax Working Group, and Dr. Fon C. Hain, Associate Director, APMEN. And of course, we have our esteemed panelists with us, and Dr. Rob, Dr. Yudhya, Dr. Lindis, and Dr. Peter, and I'll introduce them as we go along for the presentations. We have some housekeeping announcements. The participants are requested to send their comments or questions in chat box or Q&A box, and we'll try to answer them. And even if we are not able to answer, we can reply by chat or even by email later. And please don't forget to mention the name of the speaker whom you wish to address to, and also your own name, so that we can address the questions accordingly. And now we can proceed with the technical session. And we have, as I mentioned, 4 panelists, and we will be starting with Dr. Rob Commons. And but before we start the session, I would like to just highlight that while countries are resorting to intense malaria elimination efforts and there is decrease in Vivax burden, it is seen that when the prevalence is low, there is increase in proportion of Vivax cases. And this parasite, as you may all know, poses many challenges. And one of the challenge is the relapsing type of infection due to presence of hypnocytes in the liver. And till today, we do not have a safe and effective radical cure treatment because of the side effects of hemolysis which are seen with these medicines. And our panelists would be deliberating on this subject today. And not only that, I would like to add Vivax malaria has other challenges like difficulties in diagnosis due to low parasitemia, and as well as, the earlier presence of gametocytes, which can lead to quick transmission. So with this background, let me invite Dr. Rob Commons first for his presentation. And Dr. Rob is infectious diseases and general medicine physician in Ballarat, Australia, and a senior research fellow at Menzies School of Health Research, Darwin, Australia. And his research is mainly focused on ways to improve Vivax radical cure, including undertaking large pooled individual patient data meta-analysis through an extended collaboration with Worldwide Anti-Malaria Resistance Network, WAN. And he will be speaking today on the tolerability and safety of high-dose Primaquine radical cure for Vivax malaria. Over to you, Rob. Floor is yours.
Thank you very much, Dr. Neena, and it really is wonderful to be speaking today on this topic. And following up from some of the discussions that we had late last year at the APMEN meeting in Bangkok, where we presented some of this data, but then there's additional data that has come since then. So really the focus today of my talk is on the tolerability and safety of high-dose Primaquine radical cure for Vivax malaria. As we are all well aware, Vivax malaria causes both a blood stage infection, which causes our clinical symptoms of malaria, but also a liver stage infection, and that causes the relapsing malaria, which is so problematic. Unfortunately, we need 2 different treatments usually to treat both of these malaria stages, and we only have 1 class of drug that we can use to treat the liver stages, the relapsing liver hypnozoites. Within that class, we have 2 drugs, Primaquine, which we've had for a very long time, and Tefenaquine, which is a very new drug and likely to become increasingly important as we learn how to implement it. The focus of my talk today is really going to be on Primaquine rather than on Tefenaquine. So when we talk about radical cure, we need to balance two things. We need to balance the prevention of relapses, the effectiveness of the drug, with the safety and tolerability of that drug. And the most important safety aspect that is well known is the risk of hemolysis in vulnerable patients with G6PD deficiency. Now, when we think about these two things, we need to think about, for the effectiveness, the safety, the prevention of relapses, we need to think about the total dose of Primaquine that's given, and that's what's probably most important. Whereas for safety and tolerability, the daily dose is more important. And so there is a trade-off between these two aspects. There are a number of different regimens that are used and studied for Primaquine. And I'll just take you through to remind you, I'm sure you're all aware, but I'll also take you through to remind you and to explain the terminology that I'll use throughout my, my talk today. So the most common regimen that's been used over the years is the low total dose regimen. So this is a 3.5 milligram total dose regimen. So you can see here that's a green box here, and that's given over 14 days, which means that every day there's a 0.25 milligram per kilogram daily dose, or what we've classified as a low daily dose. The WHO also have recently updated their recommendations to recommend a low total dose, 3.5 milligrams per kilogram, over 7 days, which means that the daily dose then increases to 0.5 milligrams per kilogram, or an intermediate daily dose. In some regions of the world, in particular in East Asia and Oceania, the WHO recommends giving a high total dose of Primaquine. This is 7 milligrams per kilogram total dose, and that's over 14 days. So again, at a 0.5 milligram per kilogram daily dose, or intermediate daily dose. I'm just going to pause there and talk very briefly about some of the efficacy data that we presented last year, and remind you of that. So this is a paper that's in press at the moment. And this figure here compares people that got no Primaquine, people that got low total dose Primaquine, 3.5 milligrams per kilogram in blue, and people that got high total dose Primaquine in red, so 7 milligrams per kilogram. And it shows the risk of recurrence over time. And you can see that if you did not receive any Primaquine, people had quite a high risk of recurrence, going up quite rapidly. This reduced with low total dose Primaquine, and it reduced even further with high total dose Primaquine. So that if we compared high versus low total dose Primaquine, there was about a 50% reduction in the risk of recurrence. And this is really important when we think about this final box on this table, because if we're trying to give high total dose, because we think that actually that would reduce the risk of recurrence, ideally we'd give that in as short a time as possible. If we give it for 14 days, it takes 0.5 milligram per kilogram per day. But if we give it over 7 days, then it's quite a high daily dose at 1 milligram per kilogram per day. And the current WHO guidelines have a conditional recommendation against this, because the initial studies that found this suggested there may be a signal for increased safety outcomes, or negative safety outcomes with this dose. And this is really what has led to this, or part of what's led to this discussion today, because since then we've got some additional data regarding these higher doses, higher daily doses in particular of Primaquine. So we have some data from individual patient data meta-analyses, which I have been involved with and will present. We also have some data from 2 trials which I've not been involved with, so the Prima trial and an ultra-short course Primaquine trial in Papua New Guinea. And I'll present some of the data on all of these today. Before I do that, I just wanted to remind people that we're talking about 2 things. So we're talking about safety and tolerability. Safety is the severe events that can occur, the serious events that can occur. So that might be a serious hemolytic event, might be someone requiring a blood transfusion or dialysis, people needing hospitalization or death. And then there's also an aspect of whether people can tolerate the drug or the increased dose, and that can take the form of vomiting or abdominal pain, nausea, diarrhea, or loss of appetite, as well as many other things which I haven't listed. There's also an issue of what's the best way to measure hemolytic safety, and this has made understanding the risk of hemolysis quite difficult when you look across the literature, and is one of the benefits of when we pool all the data in an individual patient data meta-analysis, that we can actually use the same metric, because there are lots and lots of metrics that people have used to measure hemolytic safety. You can see them listed there on the left. We think from a pharmacovigilance perspective that appropriate safety measure to determine bad events should have two key factors. One, it should actually cause hemolysis, so it demonstrates a significant risk of actual a significant hemolytic event, which is attributable to the primaquine or to the tafenoquine, and it potentially should cause a clinically relevant sequelae. So the one we've used, and I'll discuss throughout this talk, is a greater than 25% fall. So it's caused a significant hemolytic event, it's a significant fall in hemoglobin, to below 7 grams per deciliter, which is often considered a level where you might consider a blood transfusion. So we consider that to be clinically relevant. So moving on to the first bit of new data. So this relates to individual patient data meta-analyses, and we undertook a systematic review of all the Primaquine studies, so an uncomplicated Plasmodium Vivax. Studies that included and were eligible for the analysis. We asked the investigators to join the study group, and then all the data were pulled through WARN and standardized so that we could analyze them all together. And we ended up with 26 studies in this group and over 7,000 patients. The first result I wanted to talk through was that of gastrointestinal intolerance. So you can see that this component included about 5,500 patients. And we looked at gastrointestinal symptoms on days 5 to 7. So these are symptoms after the acute effects of malaria have usually resolved and after shazondazidyl treatment has usually been completed. And from this figure, you can see that we compared 4 different groups. We compared patients that received no primaquine, patients that received a low daily dose of primaquine, so 0.25 milligrams per kilogram per day, patients that received intermediate daily dose of primaquine, 0.5 milligrams per kilogram per day, and patients that received high daily dose of primaquine, that's the 1 milligram per kilogram per day. And you can see here an adjusted percentage of the people that had these symptoms on days 5 to 7. And this was adjusted for a number of factors and potential confounders. You can see that really no primaquine, low daily dose and intermediate daily dose had similar levels of risk of having gastrointestinal symptoms, but there was a slightly higher percentage of people that had symptoms at high daily dose. Now, really importantly, we were unable to adjust for primaquine, for having primaquine with food. And that's important, as you'll come to see when I present some of the results of other recent studies. So this did not adjust for any patient having food or not having food with their primaquine. What about the hemolytic safety? Well, previously we have published a little bit on this, and we've compared people that received treatment without primaquine, as you can see in the blue line, with those that received treatment with primaquine in the red line. And this figure shows what happens to someone's or the population's hemoglobin over time. So we see here, this is your hemoglobin, and here is time up to 42 days. Initially, there's a fall in hemoglobin to around day 2 to 3, and both people that with and without primaquine fell to a similar level. And then there's an increase in hemoglobin, and interestingly, those who received primaquine seem to increase more than those that did not. Importantly, this was the population of people that had a G6PD activity of greater than or equal to 30%. So these are people with what we would classically call had normal G6PD activity. And this is very much the population average. It does not consider the really severe events that happened. The other thing it didn't do is it didn't look at primaquine dose. And this is what we've gone on and done in our more recent analyses. These analyses have been led by Megha Rajasika, who has undertaken this work. And this figure here shows the headline results. So this is the change in hemoglobin from day 0, from baseline, to day 2 to 3. If there was no change in hemoglobin, then the marker would stay on this 0 line. If there's an increase in hemoglobin, it would move to the right. And if there's a fall in hemoglobin on day 2 to 3 from day 0, it would move to the left. As you can see, for people that had no primaquine or any daily dose group, low, intermediate, or high, there was a similar fall. So all the confidence intervals overlap. And there was really no people that had high daily dose or intermediate were no worse off. In fact, they were slightly above the actual estimates compared to those that had no primaquine. Very important to note, this is the population effect, and it's adjusted for key covariates. But it doesn't look at the really severe events, because it's the really severe events that we're interested in. The other thing that's important to note is that this is for people that had a normal G6PD activity, so a G6PD activity of greater than or equal to 30%. But what about the severe events? So if we look at the severe events, as I mentioned before, we've used a measure of a greater than 25% fall in hemoglobin to an absolute measure of less than 7 grams per deciliter. And we compare the different dose groups. We can see that there was relatively few of these severe events in the no Primaquine and low dose groups, maybe slightly more in the intermediate daily dose group, but and more again in the high daily dose group. We can't draw a lot of conclusions from this, but it does look like there is a slight trend to having an increased risk of these events in the high daily dose group. These results are unadjusted. So because there's so few patients that had these events, we're unable to adjust for all the other confounders that might have caused this. Now that's in the group that had greater than 30% G6PD activity. But obviously there's two categories within that group. There's the people that have intermediate G6PD activity between 30 and 70%. And then there's the people that have truly normal G6PD activity of greater than or equal to 70%. And so we went and looked in more detail at this. This figure shows G6PD activity, so different people's G6PD activity with their day 2 hemoglobin. And you can see that from 70%, this is if the right-hand edge of that red line, from there onwards, it's really quite flat. There's no difference in the day 2-3 hemoglobin. It doesn't appear like people with greater than 70% activity have an impact on a change on their day 2-3 hemoglobin. But as your G6PD activity is less than that, your day 2-3 hemoglobin was less. And so there does appear to be a relationship between G6PD activity and hemoglobin, or potentially a risk of hemolysis between the 30 and 70%. Again, that's population, but this is a population effect, but this is the actual severe events, the ones that we're worried about. And if we look at it by dose group, again, looking at people that fell greater than 25% to less than 7 grams per deciliter, we can see that there were no severe events. It's a small population. There's only just around 50 patients in this group, but there were no severe events in people that had no Primaquine, low daily dose or intermediate daily dose Primaquine. But there were some severe events or serious events in people that had the high daily dose Primaquine, in particular 2 female patients, which would make sense as it's likely that the female patients would be heterozygous females. Now moving on to some of the other recent information that's coming to light. And this is a study that is also in press that's been led by Associate Professor Kamala Tharma. And it's the PRIMA trial. So this trial is actually not on Vivax, it's on falciparum, but it's looking at universal radical cure of treatment of falciparum. And so treating patients with falciparum with radical curative therapy, so longer course Primaquine therapy to try and prevent Vivax recurrences. It was undertaken in Bangladesh, Ethiopia, and Indonesia. It's an RCT with 495 patients that were enrolled, and it compared ACT with standard of care, which was single low dose Primaquine, with an ACT versus 7-day high dose Primaquine. That's 7 milligrams per kilogram total dose at 1 milligram per kilogram per day. So that high daily dose that we were talking about. Importantly, Primaquine was given with food during this trial, and it only enrolled patients with greater than or equal to 70% G6PD activity. So I'm not going to talk about the efficacy outcomes of this trial because I'm focusing on the tolerability and safety. But when we look at the tolerability results, we can see here results for day 2 and day 7, comparing the high daily dose compared to standard of care. And we can see that they're very, very similar. So the risk of vomiting or the proportion of patients that had vomiting, diarrhea, or loss of appetite were very similar between the 2 groups, remembering that these patients received their Primaquine with food. Overall, the risk of acute vomiting was also very low and similar across arms. So patients, 2 patients who received, had acute vomiting after Primaquine, 1 in the high dose Primaquine arm, 1 in the standard of care arm, and 1 patient vomited after their ACT. Hemolytic safety shows a similar story. Remembering these study enrolled patients with G6PD activity of greater than or equal to 70%, but you can see very similar risk of anemia at day 7 or day 2 across both the standard of care and the high daily dose Primaquine treatment groups. And in terms of SAEs, there were 2, both in the high daily dose Primaquine group. Both were considered by the site investigators to be unlikely related to Primaquine and were due to abdominal pain, one on day 7 and one on day 25. The final bit of new information I'd like to mention is a study by Jian Woon and colleagues, and that was undertaken in children in Papua New Guinea, where they gave an ultra short course dose of Primaquine. So they gave 7 milligrams per kilogram of Primaquine, not over 7 days, like we've been talking about, but over 3.5 days. And this meant that it was 1 milligram per kilogram given in the morning and 1 at night, so twice a day. Again, Primaquine was given with food, and again, all patients enrolled had a G6PD activity of greater than 70%. Now, this wasn't the inclusion criteria, but this is what ended up happening. So all patients did have a greater than 70% activity. The results are that the ultra short Primaquine course was tolerated well. There was no acute vomiting, and all patients completed Primaquine. There was a relatively high proportion of patients, 1 in 5, that had abdominal pain when they were treated with early Primaquine. And importantly, there were no serious adverse events and no severe cases of hemolysis. So, in conclusion, we can say a few things. We can say that gastrointestinal symptoms of high-dose Primaquine can be reduced by administration with food, as we've seen in the last 2 trials I presented, the Prima trial and the ultra short course Primaquine trial. There does not appear to be an increased risk of hemolysis with Primaquine at daily doses of 0.25 milligrams per kilogram or 0.5 milligrams per kilogram of Primaquine in patients with 30% G6PD activity. And this is what was shown in the individual patient data meta-analyses. But if we narrow that down further and look at G6PD activity above 30% to those 2 categories, 30 to 70% versus greater than or equal to 70%, there also didn't seem to be an increased risk of hemolysis with high daily dose Primaquine, so 1 milligram per kilogram per day in patients with greater than 70% G6PD activity. I'd like to thank everyone that's been involved in this work, in particular the people that have been a huge support and assisted me with the individual patient data meta-analyses. Many of these people have undertaken the original studies listed here and have assisted with the analysis and the work that's now in press. So Meg Rajasika, Rick Price and Julie Simpson. Thank you.
Thank you very much, Rob, for very informative presentation. And as I mentioned, we will take questions at the end of all the presentations. Now, I would like to invite Dr. Ayudhya Pitaloka. She is a professor at in Indonesia, University Sumatra Utara, and is a pediatric infectious diseases and tropical medicine consultant. And she has research collaborations with Oxford University's Menzies School of Health Research and Oxford University Clinical Research Unit. And some of her research findings have shaped the national guidelines in Indonesia for malaria management. And she also serves as deputy chair of a National Malaria Expert Committee for Diagnosis and Management. And she will be speaking on high-dose Primaquine for Vivax elimination and the studies which were conducted in Indonesia. Over to you, Dr. Ayudhya.
Thank you, Dr. Nina. Allow me to share the screen first. Yeah. Okay. Thank you very much. Good afternoon, everyone. Thank you for having me here. It's really an honor to be part of this important discussion. My presentation today is about high dose of Primaquine as a strategy for Vivax malaria elimination, particularly in Indonesia. The WHO estimates that Plasmodium vivax compromises more than 40% of malaria burden outside of Africa, and nearly 50% of the world's population is at risk from Plasmodium vivax infection. And globally, the number of Plasmodium vivax malaria cases indeed decreased from 25 million in 2000 to 14 million in 2017. But having successful control of falciparum, in the other hand, is increasing cases of Vivax, and we can see that in areas near to elimination. However, Indonesia, India, and Pakistan account for more than 80% of the global Vivax malaria case burden. So Vivax infection is another homework for us in Indonesia. This is the malaria situation in Indonesia in 2021. 92% of our regency already reached annual parasite incident less than 1 per 1,000 population, and 85% of our population already free from malaria. The focus of malaria in Indonesia is in eastern part of Indonesia, particularly in Papua, where this area is contributed to 90% of all malaria cases in Indonesia. With all our efforts so far, malaria cases significantly reduced between 2010 to 2014. However, they're stagnant afterwards, especially during the COVID as well, which indicate that malaria control has reached the most difficult stage to reduce the cases in high endemic areas, and for us also to maintain the free malaria in elimination areas. When we look at this figure, this is the proportion of our Vivax in blue color and falciparum in orange color. Around Indonesia, we can see that the proportion between falciparum and Vivax is quite comparable. And we can see more Vivax, it's more predominant in the areas that ready for elimination. We understand that the Plasmodium vivax has very unique characteristic. Dr. Nina already mentioned that the transmission can occur early because the growth of the sexual parasite along with the asexual parasite, and also the ability of under-detected parasite of Vivax. And the most important unique characteristic is the ability of the parasite to live dormant in the liver. And when we look at the strain of Vivax that circulate in our areas in Indonesia, it has the characteristic of early relapse and frequent. We also observe our patient, and we found one person can have 3 to 4 relapses in a year, plus the initial infection. With the impact also of this recurrent infection will, of course, give low impact of the quality of our people. So we are still using Primaquine as our anti-relapse in Indonesia, and Indonesia still use very low dose of Primaquine with 0.25 milligram per kg per day for 14 days. It's contraindicated in pregnant women, lactating women, and children aged less than 6 months. Of course, we recommend of G6PD testing before deploying Primaquine, but we understand that actually it's not available. The test is not available in our endemic area. Therefore, we encourage our patients to do daily monitoring of their urine color. And if anything happens or any side effect occurs, they need to go to the nearest healthcare to get help. And we also provided guidelines for our healthcare personnel in the field. We started to use Primaquine at the age of 6 months up. And for patients with G6PD deficient, we will give weekly doses with 0.75 milligram per kg once a week for 8 weeks. Of course, we would also like to encourage the patients to evaluate their urine color and monitor the hemoglobin level quite close. And there were several studies that have shown that 14 days of Primaquine has given us the very poor adherence. And the study conducted by Dr. Rini also in Indonesia, in Papua, also showed that 14 days of Primaquine without supervision will only give adherence less than 20%. So with the effectiveness of Primaquine based on the total dose, if the patient cannot comply with 14 days of Primaquine, so the effectiveness will be questionable. So we did this large study called IMPROV, which involved 7 sites from 4 different countries. It's a randomized double-blind placebo-controlled trial with 3 different arms. The first arm was using 0.5 milligram per kg for 14 days of Primaquine. And then the second one was using high dose of Primaquine, 1 milligram per kg for 7 days. And as control arms, we use placebo. And in the study, we have enrolled more than 2,000 patients, and nearly 50% of the patients in the study came from 2 sites of Indonesia in the Sumatra island. And from the result, we could see that the incidence rate of symptomatic recurrence of Vivax was 0.18 recurrences per person year in Primaquine 7, and it's comparable to 14 days of Primaquine, which has recurrences of 0.16. And this significantly lower than placebo, which has 0.96 recurrences per person year. The number of recurrences that we could avoid by giving Primaquine 7 days was 781 per 1,000 patients, which also comparable to our 14 days Primaquine, which can avoid 1,800 recurrences. And at the 2 sites of Indonesia, which use dihydroartemisinin along with Primaquine, the incidence risk of symptomatic Vivax recurrence were between 28 to 39% compared to the other sites that was using chloroquine has the recurrences rate above 50%. We understand that if we increase the dose of Primaquine, we would see more of the side effect. And in the study, we can see significant higher number of abdominal pain in our 7 days of Primaquine. It's about 59% of the patient compared to 54% from the 14 days of Primaquine. But we understand that this actually could be mitigated by providing food to the patient. What we did in our study, we provide the children with milk and biscuits, and we also ask the patients to have their meal before they consume Primaquine. So this is my last slide. We know that Plasmodium vivax pose a specific challenge in achieving elimination, which requires both better diagnostic tools and also effective radical cure. We know that from our study that short duration and high dose of Primaquine could be an option to improve adherence, because our 14 days Primaquine has very poor adherence, and this short duration with higher dose can also improve the efficacy, and we need to combine it with G6PD testing as well. We understand that abdominal pain might increase with higher doses of Primaquine, but this can be mitigated by providing food. That's all from me. Thank you very much for the opportunity. Good afternoon, everyone.
Thank you, Dr. Yudan. And it's really an eye-opener to know that if 14-day treatment, I mean, the compliance is a major issue, which sometimes is not recognized. Although, because programs are not able to do G6PD at point of care, that's why they resort to 14-day treatment, considering it may be safe as you give lower dose. But definitely the results, clearly state that there needs to be some mechanism to rectify this. So we will have questions at the end after all the speakers have completed their presentations. And now I would request Dr. Lindis Vinny, who is a medical officer and in charge of case management unit of National Vector-Borne Disease Control Division, Ministry of Health, Solomon Islands. And he will be speaking on, his title is very interesting and catching, Are We There Yet? So over to you, Dr. Lindis.
Sorry for that. Just a small. I hope you can see my screen.
Yes, we can. You just have to put it in presentation mode.
Mhm.
Dr. Phone, you could, can you, yeah.
Okay, thank you very much. Good afternoon. Well, it's afternoon now in Solomon Islands, but anyway, greetings from Solomon Islands. I will just touch on a few things in terms of the possible implementations, what the challenges are, and the kind of environment the possible increase in doses would entail in a country like Solomon Islands. So just like what has been happening, Solomon Islands has seen some significant changes in the epidemiology of malaria since the 1990s. Unfortunately, towards after 2015, we started to see a resurgence of malaria, particularly a change in epidemiology from Plasmodium falciparum to Plasmodium vivax being the dominant species. And that has given us this challenge, as was shared by Indonesia as well, in terms of implementation of radical cure for Plasmodium vivax using Primaquine. We currently also use 0.25 milligrams per kg body weight per day. And we don't have too much data on the actual implementation or adherence to that regime. So my title of the presentation, as was said, is "Are we there yet?" And I would like to just discuss briefly what it entails in terms of Vivax radical cure. So we have just currently started doing G6PD screening in 9 of the provincial hospitals in Solomon Islands. That represents 9 provinces. Our population is quite small. It's approaching around 750,000 people. And included in those 9 provinces are the 8 urban health clinics in Honiara. The G6PD prevalence published in studies that were conducted in the early 2010s was around 20.3%, but that was mainly in one province, and so this data was not representative for the whole of Solomon Islands. And the things that I would like to highlight in line with WHO recommendations as well for radical cure are the 3 main pillars that we see as G6PD screening, which is what we have started to do with the SD biosensor. And then there's the issue of a good pharmacovigilance system as well. This system of pharmacovigilance is something that is just slowly being adopted in Solomon Islands for all drugs. When speaking to the pharmacy division in relationship to trying to increase the dose of the possibilities of increasing the dose of Primaquine, they said that this system is just being initiated, and they are going to strengthen it over the years. In addition to that, one of the issues we see as well is the blood transfusion services. I'm sure that some of the studies that have been done, including in Solomon Islands as well, there has been some instances that we actually had patients that required blood transfusion during the studies. What I would like to point out is that those things are during controlled trials where most of the services are available and patients are easy to be referred to hospitals because of the controlled nature of those trials. However, in real life, blood transfusion services in Solomon Islands is only based in provincial centers, and we have a very wide coverage of area that is mostly by sea, travel is by sea. And even in these transfusion service centers, we only have whole blood that can be transfused in packed cells. But the biggest problem with that is that the availability or the availability of donors to support this transfusion services. So from countries, small countries like Solomon Islands, the biggest challenges that we can envision with a possible increase in dosage and this thing for radical cure is more the supportive services that is to be provided by the government and the Ministry of Health. So in considering the implementation of Vivax radical cure, like Dr. Commons has said, there's issues with safety and tolerability, which can be addressed. And there's also the issue of the prevention of relapses, which is why we've seen from the studies that they've done that the current regime that we are adopting in Solomon Islands is not working. And we have also seen that from studies that were conducted here as well that supports that the 0.25 milligrams kg body weight is probably not adequate for the implementation of Vivax radical cure. So I'm just putting up some data that we have just recently seen by utilizing the biosensor screening. We screened about 4,600 patients in those centers that I've mentioned already. And the prevalence of G6PD deficiency in males is around 18% and females of about 13%. And in females, there was about 9% of intermediate deficiency. But what I would like to highlight, there's a typo error here. What I would like to highlight is what was defined as per manufacturer of the SD biosensor, that anything less than 7 grams per deciliter on the hemoglobin reading would be unclassified. So we use that as a sort of indicator to see how many of those populations were less than 7 grams per deciliter. And it was about 5% of the population, which, taking into consideration all the other issues in terms of implementing Vivax radical cure, it's something that we as a country would really need to improve those supporting services to ensure that this move is actually going to be safe, and at the same time we will be able to prevent the relapses as well. So consideration of accessibility and healthcare delivery services is also something as a program we really need to consider as well. So I hope that was just a small indication of what some of our other countries will be facing in terms of this increase in or implementation of Vivax radical cure. I hope that will contribute towards the discussions. Thank you.
Thank you very much, Dr. Lindes, and it's really good to know. I mean, the pharmacovigilance and G6PD testing and all these safety measures are being taken in the country, and this will really go a long way in adapting even if when we talk about single dose cure or high dose Primaquine regimens. Thank you very much. Now, I would like to invite Dr. Peter Olimis, who is a medical officer at World Health Organization, and with over 24 years of experience as pediatrician and clinical pharmacologist. And since 2001, he has been working in WHO Global Malaria Program in Geneva. And he is actually the person who has been responsible for WHO guidelines for treatment of malaria, which we all refer to. And he has also served as co-chair of Rollback Malaria Country and Regional Support Partners Committee since 2009. and he has contributed significantly to fight against malaria, if we say, because whatever guidelines are prepared, they do have impact on and the countries adopt treatment policies according to that. So over to Dr. Peter.
Thank you very much. Good morning from Geneva. You can see my slides.
Yes, we can see. You have to put it in the presentation mode, maybe.
Okay. Not better?
Yeah.
Okay, thank you very much.
Perfect.
And thank you for the opportunity to be part of this. And I think it has come at a very timely, it's come in very timely. I will just run through my slides. Essentially, I'm presenting to us what the current guideline recommendations are with regards to treatment of uncomplicated non-falciparum malaria. And just as an orientation, so people would understand that since 2021, we have changed the format in which we present our guidelines. We have moved from intervention-specific areas to having a consolidated malaria guideline. So in the past, we would hear of the malaria treatment guideline, malaria vector control guideline, but now all of that has merged into one document, which is the WHO guidelines for malaria. So you have a section on prevention, a section on case management, a section on elimination and prevention of reduction. I think the beauty of this, and it becomes very relevant in the context of our discussion, is that it's a living document. So we no longer have editions like in the past, where it took 3 to 4 years to move from one edition to the other, first edition of the guideline to the second to the third. Now the review, it's on an ongoing basis as evidence becomes available to the relevant sections of the guideline. So it was just last year, December, that we published an update of the guideline that that made recommendations or changes to the use of the short course Primaquine, and to reassure us that now that more evidence has become available, certainly we look forward to using those evidence to update the guidelines on a continuing basis. So that's very, very important. I just want to emphasize here, because I think these have been misunderstood for quite a while. The objective of treatment of Vivax malaria, there are twofold. One, to cure the blood stage of the infection, and also to clear the hypnozoids from the liver to prevent the future relapse, what we used to call the radical cure. So the two aspects. The question is not, should we use anti-relapse treatment? Should we use Primaquine, which is what we have right now? And the answer to that is yes. And so when as WHO, we had recommended that GCSPD status, it was not meant to exclude people from receiving Primaquine or anti-relapse treatment. The GCSPD status was to help to determine how best to deliver Primaquine safely. But anti-relapse treatment is a core part of the management of Vivax malaria, and it is recommended that way. So we should and we must use anti-relapse treatment, but how we use it is guided by GCSPD status, because the risk and the harms of not having anti-relapse treatment far outweighs the benefits of anti-relapse treatment. So I will move on very quickly. Like, I know we're talking about anti-relapse, but it's just necessary to remind us of the treatment of the blood stages, where right now we say in areas with chloroquine susceptible infections, you can treat with chloroquine or an ACT. However, in areas of chloroquine-resistant infection, we recommend the use of an ACT. Previously, in this recommendation, we had excluding women in the first trimester of pregnancy, but that is no longer the case because ACTs are now recommended for use in the first trimester of pregnancy. So ACTs, this can be used in the first trimester of pregnancy, particularly artemether lumefantrine, but where that is not available, any of the other ACTs may be used also for the treatment of Vivax. And when it comes to the preventing relapse, a good practice statement that the status of GCSPD status of patient should be used to guide the administration of Primaquine for preventing relapse, not to be used to decide, is to guide the administration. The recommendation is that the anti-relapse treatment has to be given. And in 2015, when we made this recommendation that to prevent relapse, children and adults, except pregnant women and infants less than 6 months of age, unless they are known not to be treated with a 14-day course of Primaquine in all transmission settings. And then just last year, we had an update to that recommendation where the short course standard dose Primaquine treatment, so that is the 0.5 milligrams per kilogram body weight per day for 7 days, was recommended as an additional option in terms of having a short course therapy. And following what I've just been presented, the committee felt strongly that this would improve adherence to treatment. And so that was recommended, and the short course treatment, standard treatment of 0.25 milligrams per kilogram body weight over 14 days was recommended that this could be used as 0.5 milligrams per kilogram body weight a day for 7 days. However, like has been mentioned, based on the level of evidence that was available then, the short course standard high dose had a conditional recommendation against. So that would be the 1 milligram per kilogram body weight per day for 7 days. And most of these had to do with the tolerability in terms of gastrointestinal effect, and also did not have enough robust data at that time, the issues around hemolysis. And so we're happy now, just seeing this data now, what has been presented, certainly we have additional data to relook at this recommendation. And I'll just make a reference to what the recommendation says right now. In one of the footnotes, it says that taking the drug with a meal may mitigate the effects of the gastrointestinal effects. That was what we knew as of that time, but from what we're hearing right now that has been presented, it's more concrete to say yes, that taking it with a meal would actually mitigate the effects of the gastrointestinal non-tolerability effects of the drug. So the additional data that becomes available is very helpful. And just to complete the picture, we also have in a guideline that in areas where GCSPD deficiency and they cannot determine the GCSPD status, they may consider the use of 0.75 milligrams per kilogram body weight once a week for 8 weeks. And that for pregnant women and breastfeeding women with breastfeeding children less than 6 months of age, where Primaquine is presently contraindicated as per the guidelines, they may consider weekly chemoprophylaxis with chloroquine. However, once they have completed breastfeeding, and then a Primaquine treatment course should be provided them. So I think that's the end of my presentation, and that's the recommendation the way it is currently. But like I said, we now, and just listening to what has been presented in this webinar, gives an indication that there have been additional evidence available since we released this recommendation, and since we have a living guideline system now. We actually can include some of this discussion in the next guideline development group meeting, which we plan to have before the end of this year. and we'll see how it pans out. So I would end there and ready to take questions if any. Thank you very much.
Thank you, Peter, for the excellent presentation. And, as you mentioned, the living guidelines, and now the updates are available. I mean, in last 1.5 years or so, we have seen 3 or 4 updates, and it's really easy to capture the information. And also, as it was discussed, being part of this exercise earlier, I mean, whatever are the changes, they are also highlighted, so the reader knows what update has been done. I think it's a really good, and of course, still there's a lot of debate on each topic when the guideline needs to be updated. We understand that, and thank you very much for this presentation. Okay, so now let's have question answer session, and I have 1 or 2 questions myself, and then I can kickstart that session. And we have few questions we had in the chat box. Few of them have already been answered, but still I would like the speakers to add if they want to comment on those questions. So first to Rob. See, when you do research on Vivax, and especially for anti-relapse treatment or for the radical cure, there are so many limitations you must have realized. So how do you, I mean, first of all, would you like to say what limitations you have experienced because we don't have markers for relapse or new infection, and then the issues related to compliance we can't objectively assess, and the safety, of course, sometimes we don't even get information on the adverse effects in the countries, but whether they are occurring or not. So many limitations. Would you like to highlight some of them, and which you have faced during your research activities?
Thank you, Nina. I think it's a very important question because, as you say, there are a lot of limitations with any research that we undertake, and in particular when we're trying to deal with Primaquine and some of the issues that arise from that. So I guess the first one is one that is key. So we don't have a perfect way of identifying relapses. We use recurrence as a marker of relapse, and this is where determining what time frame we're looking at, and the time frames we've generally chosen have been follow-up for 180 days comes in importance. But many people would argue that potentially you could even shorten that time frame. Now, there's the reason that you might look at that is that you get new infections coming in, and they'll be counted as recurrences. So the longer you go out, the less relapses you'll have, and the more new infections you'll have. The shorter you follow up, though, you'll miss long latency relapses. And so that is a very, very difficult thing to capture. I think the other thing is that, yes, we have mixed data coming in. So some of and I guess this is where there is a benefit from using individual patient data and reorganizing that into a consistent, standardized data set. Because some studies look at data, it's like with a standard trial, you'd say, okay, this person got 3.5 milligrams per kilogram, and this person got 7, and you just compare them across. Whereas we actually calculate what dose they got. Some patients, we get the actual doses, the tablets that they get, about half the studies, and the other half, we calculate that based on the study protocol. So this person weighed this much, they're expected to get this. But we always do a secondary analysis that's based just on the actual dose that they got. And obviously that would be, we would mention that if it differed to the main result. So I think there are 2 key aspects with efficacy. Safety, as I mentioned with my talk, the different metrics used make it very difficult to measure across. But again, using the individual patient data, we can actually use a standardized metric because we have the actual data. And so we can standardize that across studies rather than trying to use aggregated data. But it is an important thing to discuss.
Thanks, Rob. And there were a few questions in the chat related to your presentation. Of course, like one by Sukant Pandit, which were answered by Rick. So there was a confusion. There sometimes is a confusion between when we talk about high dose. Is it a high total dose or it is a high daily dose? I mean, even when you read through the lines, it becomes a little tough. So that was answered by Rick, and there was another question by Sukant on depot preparation, which of course again, you know, if we are talking about 14-day for safety and then 3-day or 7-day, we want to do G6PD test, and if it's a depot preparation, I mean, it's just like we have now single dose cure, so the safety may be another issue for that. And there was also from the same person was a question on concentration, whether it should be related to MIC, whether the efficacy would be concentration dependent or duration dependent. We know it has also been mentioned, it's a total dose rather than the duration. So these were few questions which were answered also, but if you want to add to this, anything you may like to respond. And then I will say, okay, the next question I'll take it after this. So would you like to respond to this comments?
Thanks, Nina. Thanks, Dr. Nina. I think the one thing I'd like to highlight is that we do have another treatment option other than Primaquine, and that is single dose tefenaquine. That obviously has some issues that are being worked through, namely whether we can give it with only chloroquine or whether we can give it with drugs other than chloroquine, and also has the issue of safety, because once it's given, you can't take it away, and so, or you can't stop it, as you can stop Primaquine during the treatment regimen. And so if you do give it to someone and it causes hemolysis, that is a potential safety risk. So those treatments, those issues mean that there has been slower implementation than perhaps many of us, or probably everyone would have liked, but and it's why I'm sure it hasn't yet reach the WHO guidelines as well, because there are those issues to work through. But there's lots of work being done on those issues and lots of ongoing discussion about those things.
Yeah, and the last one is from Bob Taylor. Why cutoff for 70%?
I presume that was in relation to the final 2 trials, and the reason for that was that just as tefenaquine is restricted to patients with 70%, to exclude the majority of female patients who are heterozygous for G6PD deficiency, and thus potentially at risk of hemolysis. These 2 trials gave high dose Primaquine, so at least 1 milligram per kilogram per day, in one case up to 2 milligrams per kilogram per day, and they didn't want, it was considered safer to restrict to those patients. But it's a very important question as to what the safety is in that 30 to 70% with high daily dose. At the moment, it would suggest that there is a signal of some adverse events occurring in patients that are female and heterozygous for G6PD deficiency.
Thank you, Rob. So let me move to Dr. Yudhya. I mean, this was really a very nice presentation from Indonesia. And there were questions from Bob Taylor related to the dosing, I mean, the different weight band dosing. And is it easy to implement? And also you mentioned why not use 7.5 milligram tablets so that it will be easy administration. So I would please respond to this, and then I'll go to the next one.
Yes. Thank you, Dr. Nina. Thank you, Bob, for the question. We're providing the tables for to make it easier for our health personnel in the field, so they don't have to calculate the according to milligram body weight, but it's already with whether they want to do it with age base or weight base, they can choose. And it's easy for them. Then they have to calculate individual with the individual body weight. We don't have the 7.5 milligram tablets. What we have now, it's only 15 milligram. And it is, of course, quite difficult for small children if we need to divide the dose, especially like small children that will only need like a quarter of the tablets. So it will be difficult because we need to crush it. And yeah, and also some study also mentioned that it might be underdose for the children because of this, but we don't have any other option for now. So we use this. Thank you.
You are muted, Nin.
Side by side, I was looking at the chat. So by Ankana, there was a question, which G6PD testing method is being used wherever it is used in Indonesia?
Yeah, in Indonesia, we don't have G6PD testing yet. Of course, in our guidelines, we recommend to test for G6PD before giving Primaquine, but that's very difficult. The option for G6PD testing only available in the city and not in endemic area. So what we do is we encourage the patients to monitor their urine color, because the hemolysis usually occur after several doses of Primaquine, after 3 to 4 doses. And what we observe is the hemolysis occur in the first week. And if it's safe in the first week, it's probably safe on the second week. But we don't have the option for G6PD testing yet. But in improv trial, we conducted fluorescent spot tests before, for our patients.
Yeah, I mean, it's a real good practice. I mean, it is recommended in many countries, like even in India, that one should monitor and ask for the color of urine. So as if this is practice, so just, I mean, I would like to have not a clear-cut figure, but how many cases have you, or is it very frequent to get cases who show hemolysis, or, I mean, leading to the interpretation that they would be G6PD deficient and they had Primaquine?
Yeah, I can say that Indonesia is very huge. The percentage of G6PD different in different places. From our place in Sumatra Island, where we also conducted G6PD prevalence, the prevalence is quite low. It was around 2 to 2.5%. So, but in the other island, it's probably can reach near to 10%. And we're actually not sure whether the patients really take their 14 days or either they take 1 week. But so far, from the information that this Primaquine that we're giving so far is quite safe, and it's not many cases that came with hemolysis.
Thank you. Thank you very much. So to Dr. Lindis, was a question of from Karen Baines, that what is the recommendation for radical cure for less than 7 gram per deciliter? This is a at that level you don't get the G6PD level, as it says, unspecified. So is there a recommendation, or these patients are not given Primaquine at all? Dr. Lindis?
Yeah, thank you for the question. According to our treatment guidelines, it would be still the same for like Indonesia as well, that we still advise patients to monitor urine and all those things. So the treatment guidelines, we haven't addressed anemia as in terms of Primaquine. So it's more just the recommendations to monitor urine. But given that that level of anemia is quite risky, we also advise the patients that they should try and improve the anemia before treatment with Primaquine.
Yeah, you mean at present the recommendation is like that, but this was the results you showed when you use SD biosensor in a study. So,
okay. Yeah, that was because that now we have the availability of the biosensor and we can get HB readings as well. And we noted that 5 to 10% of our patients are actually below 7 grams per deciliter, which would also impact the possibilities of increase in Primaquine dosing so that was why I put it up, just to highlight that point, that we do have a significant amount of anemia normally amongst patients that we've screened.
So now that we have these POC available, and gradually this will be in when we use single dose cure, it will be used more widely. So do you think it will be easy to adopt or implement in the country with the experience of a small study you have done?
Yeah, I will also refer back to the WHO from Peter as well, in terms of that it should be a guide for treatment with Primaquine. If we look at it from Solomon Islands' point of view, if we look from G6PD deficiency alone, we are approaching like 20% of the patients with Vivax malaria would not qualify for G6PD Primaquine treatment based on that alone. And I think that's a very significant amount of patients to put them off the option of radical cure. So we need more guidance on the actual implementation. I think that was the point of my presentation, like the actual implementation, given the data that we are having, given the local context.
Yeah. Thank you. So, Peter, now we know the recommendations and the issues we see when formulating the guidelines, because one has to keep in mind what is the available in each country, and different scenarios, different epidemiology, and different interest, to adapt all this and considering. But I don't know, when we see at country level, we don't hear much about the issues related to hemolytic side effect. And when we say that G6PD level should be done, and as best practice, WHO does recommend that. But I don't know how easy would it be for advocacy for the national programs to do it mandatorily, especially if we are talking about high dose, or even with the same dose, shorter course regimens. Don't you think this can be a challenge if G6PD test is not done, which is the case at the moment? Although they say, many countries do say that they do pharmacovigilance, or they have, visits to follow up, but in practice, many times it doesn't happen. So if we recommend higher dose or shorter course, do you see any challenge in that? And what WHO is considering, that how to, enforce this, or how to make countries adapt these safety measures? Over.
Yeah, thank you. There will always be challenges with implementing any recommendation. And like Rob said at the beginning, which is what we're trying to do with Primaquine treatment or anti-relapse treatment, is balancing the benefits with the, and that's why I started, and I'm happy the Indonesia presentation. We must all agree that anti-relapse treatment, Primaquine now, or maybe when we have other drugs like tafenoquine, is an integral part of management of the Vivax patients. The question is not, should we or should we not? We should. It is, how do we best do this, ensuring the safety of the patient? And I think that's where the challenge is. And there are several scenarios, like was presented in the Indonesia situation. They have, as it were, not able to do G6PD test everywhere, but have built in a system where the patient or the individuals are informed, monitor this, and once this happens, you stop that. So there is some degree of supervision and knowledge that these are the potential. So in essence, that risk is still there, but the point is you have empowered the people to say, look, it's best for you to have the Primaquine treatment, but this risk is there, monitor this, and this is what you do. So at the end of the day, I say we make guidelines, and most times, or all the times, our guidelines are driven by the science and evidence available. Countries use the guidelines to develop policies. Those policies will be in the context of what is implementable and what is in the best interest of. So really, the guidelines, the way we have it now, makes provision for everyone to get Primaquine one way or the other.
Yes.
There is nothing in our guideline now that says you must not. It makes provision for everyone. So it's how you implement that together. And since I'm on that, maybe I just update and let us know what we have in the pipeline. I mentioned when I was presenting that we have a guideline update process ongoing. We are expecting to have the first meeting sometime before the end of the year in November. One, we're looking at tafenoquine for anti-relapse treatment. So that is certainly one of the things we're looking at, and the review is almost complete for that. And when it comes to Primaquine, several things. One, right now we have indicated contraindication for children and breastfeeding mothers up to the age of 6 months of age. So we're really looking at breast milk and all of that to see, can we reduce this further? What stage do we say this is contraindicated? And what is the extent of the tafenoquine in breast milk and all of that? So that's one area we are looking at. The other thing we're also looking at is the issue of low total dose now. I'm not talking about daily dose, total dose. The low, that's 3.5 milligrams with the 7 milligrams. And from what has been presented here, we certainly see, irrespective of the subspecies of Vivax, that using the higher dose of the 7 milligram is superior, so to say, to the 3.5. So that's one thing that we are reviewing. And then, of course, lastly, to see between when we released the recommendations last year and now, can we update or give further guidance for the high daily dose. Okay, now high daily dose, that's the 1 milligram per kilogram body weight per day. Maybe we can give more situations and parameters around where it can be used. And whilst on that, somebody asked a question on the chat, what is all this issue about low certainty of evidence and technologies that we use in the guidelines? Again, this is very guideline related, and the methodology that we use, the grades, table, and all, where you try to link the evidence to the recommendation. I always say you start with the recommendation. So there are places where we have strong recommendation, very low quality of evidence. In essence, you know, just to put it in a very simplistic way, we're not saying the evidence is of poor quality. We're saying that this recommendation, from the little evidence we have, points in the direction that this is something that should be done. And that's why it is strong recommendation. However, the evidence that we have is either indirect, in the sense that you're making a recommendation in women and the study was done in men. So no matter how robust that is indirect. Or there were studies that were not randomized controlled studies. So that's what all of that means, and encouraging that more data is required to strengthen the directness and the robustness of the evidence that supports the recommendation. But once we say it's a strong recommendation, we are saying this is something that should be done. And even when we say conditional recommendation, like for example, for the 1 milligram per kilogram body weight, we said conditional, meaning that conditional against, meaning that we're not saying don't do this, but there may be situations and gather the right evidence like it's coming up now that you may want to do this. But those are strict guideline technologies. You will see in the guidelines in the first chapter, I try to explain what all of those mean. So I said all of these and things we plan to update in the before the end of this year, because I know there are experts on this meeting, I know with information I know, and I'll be reaching back to you for all the information and necessary data to help us come up with clearer recommendations. Thank you.
Thank you, Peter. We can't leave you here. There are a few more. I mean, of course, one few are simple. I mean, there was one question is that can it be Primaquine in low dose be given to breastfeeding mothers, because otherwise it will take long time to be when they can after delivery they can be given Primaquine. And so that is one question. And other is about the MDA of Primaquine, which of course I think already mentioned in the guideline. So you can just, clarify those two.
Okay, yeah, for the breastfeeding mothers, can we use lower doses over a long period of time? We don't know. And that's why I said part of what we want to review is how best do we give Primaquine to breastfeeding mothers. Because right now, the only reason why we say there's a contraindication for the first 6 months is because of the baby. And so certainly part of what we're going to review, and what's the extent of Primaquine, the breast milk, is this enough to be of concern and all of that. So I think we have some more evidence, some more data now that would help with all of that. And for the MDA with Primaquine, in the context of wanting to reduce the transmission reduction and all the Vivax, it is not recommended.
Thank you, Peter. Since we have time, I mean, there was another question from Patricia Graves to Dr. Linders. I mean, that you mentioned the 0.25 milligram per kg for 14 days regimen is not working. So do you think it could be lack of evidence or lack of effective dose or lack of adherence? I mean, this is a question which every country or researcher will ask. I mean, you never come to know about it. So what would you like to say on this? That would it be that the compliance is the issue when it comes to 14-day in your country, 14-day treatment, and that is why it may not be effective? Over to Dr. Litis.
Yeah, thank you for the question. I think it's a bit of both, more so previously with compliance. And as people get more educated, there's more knowledge on the reason for giving Primaquine, we've seen a bit more improvements in compliance. But having said that, there has also been a comparison between a study on Primaquine, which does reflect the findings of other countries as well in terms of recurrent Primaquine within 30 days of, so those were under controlled conditions. So I would say a bit of both. It's both the compliance because of the patient's knowledge of why to take Primaquine and such, and also from the low dose as well.
No, in fact, it's well known. During the acute illness, patient will take any medicine or any prescribed treatment. But the moment the patient is hale and hearty, the tendency to skip the dose or treatment is always there. So compliance would always be an issue when you are treating beyond 3 days of the acute infection and fever. And so there were a few other comments, not questions, rather there's some. Dr. Mohanty said that it's not possible to know J6PD status, and therefore, how can the high dose Primaquine be given? And definitely, we know if it is high daily dose, there would be more risk of hemolysis. But this is a problem which has been discussed, and that point of care tests now are available. Maybe things would be better. And there other I can see now popping up, like, what about MDA of chloroquine in an outbreak without RDT testing or microscopy? I don't think we should be going into that. But as related to the mass treatment with Primaquine, WHO has clearly mentioned that this is not a option of choice, and this may not be given, although some countries are still giving that. And many of the questions, I think, maybe if my other colleagues from APMEN, I mean, if there is a burning question which I may have missed, Manash or Kerry, you may like to say. I mean, I think I have tried to.
Yeah, I think
please.
Rob has his hand up there.
Yeah. Rob.
Thank you, Dr. Nina.
Sorry.
No, not at all. No, I was just wanting to round out some of the discussion, because I think a lot of the comments in the chat and some of the questions and And what Dr. Linders and Dr. Ayoade have talked about, a lot of it relates to implementation, and Dr. Peter as well, implementation. And I think that is the real challenge on the ground as to how to implement. And we've seen a nice example with what Dr. Ayoade presented, where people are unable to do G6PD deficiency testing but are using urine. I know there's currently ongoing studies looking at whether a day 3 review, a follow-up on day 3, to try and capture people that are at risk of severe hemolysis can be identified, and their primaquine can be stopped. And this is something that is ongoing, and results will hopefully be through fairly soon for some of that. So I think that's a really important question, especially if we consider going to higher doses, and if G6PD testing is not as available as we would ideally like it to be.
Yeah, you have really well summarized it well. So basically, we have seen, I mean, the question is why programs would like to go for a low daily dose. I mean, you can stop it, and if anything is detected, or many times it may go unreported, or because patient is not taking the medicine. But if it is a sort of a supervised or a shorter course regimen where you are ensuring that patient is taking high dose, there is no choice. I mean, one has to do the G6PD testing. And as now we have RDTs for malaria and point of care tests, which become so easy to do and inexpensive, we hope that for G6PD also, I mean, now we have one test, but maybe in future we will have better options, and then this riddle of relapsing malaria may be solved to some extent. And of course, compliance issue can be resolved with single dose treatment. So I think we really had a good discussion, and of course, as I said, for Vivax malaria, there will be some questions which will be left unanswered always. But all researchers as well as Peter is working hard to handle those. And because, as countries go near elimination, definitely one has to take care of Vivax malaria. So thank you all the panelists for giving great presentations, and also the participants for their active participation. If we have missed answering some questions, we can still answer it later, and maybe some answers have already been given in the chat. So, Manash, would you like to have the poll right now? So you can answer just click on the answer and that will be submitted. So while everybody is answering that poll, I would like to thank again everyone, and especially the team. Without their hard work, this session would not have been possible. Sincere thanks to Caroline Lynch, Mana Shrestha, and Dr. Phone for their putting in their hard work.